All right, good morning and thank you for keeping it Citizen Television this Wednesday. We really appreciate your time and company. Health and Lifestyle is the segment that begins right now, but we really appreciate you who joined us when we started this program until now. I take it over from Ayub Abdikadir and want to just have a conversation around looking at the state of healthcare in our country this morning. A lot of issues have been emerging. There are many questions that have been raised with regards to the government's plan to implement the universal health coverage. Of course, the transition from NHIF to SHA. Questions have really emerged now that are now shaking the success of this Kenya Kwanza's administration's plan, and it was actually one of the biggest campaign promises that they gave Kenyans. We are also having this conversation at a time when we are not out of the woods when it comes to industrial action by healthcare workers. The clinical officers are now officially on strike. Pictures that are not new in our country. We've had this strike such like a perennial problem in our country when it comes to the health sector. And we want to talk about where the problem is and the general status of our healthcare this morning. I'm having this sit down with a panel of two gentlemen with me in studio this particular morning. On my far right, we have Dr. Brian Lishenga. He chairs the Rural and Urban Private Hospitals Association. Asante for creating time. We also have with us this morning Peterson Wachira, chairperson, Kenya Union of Clinical Officers. Asante sana for creating time for us this morning. All right, so we want to begin straight away this conversation and sort of dissect and give a diagnosis on the state of healthcare this particular morning. A lot have happened in the last few weeks. It's actually one of the sectors that keeps shifting when it comes to issues that are emerging. But I'd like us to begin, it's morning, and maybe let's begin by a different way of looking at it. You're on strike as clinical officers. If you had to describe it in terms of temperature, how things are they hot? Are they warm? Are they cold? What should we expect?
Wow.
Just an opening statement, one word. Is it hot? Is it cold? Is it warm?
It's very hot.
It's hot. Things are hot. All right. Yes. Brian, you released a survey, the latest one, looking at the status of the SHA, the SHIF, is it? Tell me, is it hot? Is it warm? Is it cold? What are we looking at?
Well, SHA, people, it's always SHA. It's very, so is hot bad or hot is good?
Hot is bad.
Things
are hot.
It's extremely hot. It's boiling over.
All right, so there you have it. You can begin to see what the status of healthcare is looking like this particular morning. We're also hoping to have a representation from the National Assembly Health Committee to answer to some of the questions with regards to how they have played their overall mandate in ensuring that we are not where we are as a country as it is this particular morning. But unfortunately, that did not happen. Either way, we continue to have this conversation. Let me begin with you, Peterson. It was a threat. I remember we were here around January, mid-January thereabout, when it was a threat to go on strike. And then there was that talk, I think, between you, the Council of Governors, and the Ministry of Health. And then we had that probably the talks bore fruit and you went back to work. Why are we here again? What's happening?
Yeah, thank you, Safin. And it was not actually a threat. And thank you for giving us this platform, because I think we really need platforms to talk about health. I feel that sometimes we do not talk about it enough times, such that politicians do not really grasp what is demanded by Kenyans in terms of health. But coming back to our strike, in January, we went on a strike for a record 3 days. And everybody came out, from the ministry to the Council of Governors. We saw a lot of goodwill. And even a resolution was done in terms of SHA, because we went on strike because of two issues. One was the Social Health Authority. And if you remember, this is an issue we started raising in October last year. In November, we said, okay, we do not want to go on strike. Why can't we demonstrate so that we don't have to go on strike, but then our issues can get addressed? In December, we held demonstrations. We went to the ministry, we went to Parliament, we went to the Social Health Authority offices. Nothing happened. It's only after we went on strike that now within the 3 days, we sat and they said, hey guys, why don't you give us 21 days so that we resolve the issue of SHA together with the issue of the return to work agreement. PS Harry Kimtai, who is in charge of SHA, the Council of Governors represented at the highest level, the vice chair of the Council of Governors, the chair health, the chair HR, they sat and signed a resolution and directed Social Health Authority and told them, guys, the law says this, you are going against the law. Can you comply with the law and onboard clinical officers into the SHA platform? Mm-hmm. 4 weeks after, they have not done that. Nobody would have thought that actually the people operating SHA would even ignore and insubordinate the PS and the Council of Governors. And that is what we are seeing now. The other item on the return to work agreement, last year, we went on a strike for 99 days under the county governments. That strike was because they had refused to obey an order of the court to come to the table and negotiate and conclude a CBA. Then the same court, after realizing we have gone for an extended period on strike, gave further orders. Can you enter into a framework? They called it consent. That then shows how you are going to resolve these things within a specified time. We did that, and that is what we call a return to work formula. Mm-hmm. We took it to court as an agreement, both of us, the employers and ourselves. It was registered and came out as a court order.
So this was the counties and yourselves?
The counties, the Ministry of Health, and ourselves. Okay. It came out as a court order, and the deadline to implement those things was by 1st of September 2024. We are in February. In January, when we met, they said, okay, give us 21 days. We know that we have a responsibility. It's our agreement. We are going to implement these things. After 21 days, we have not implemented. Mm-hmm. We only negotiated a few days for the CBA, but then we are told we are waiting for other parties.
Let me take you back, Wachira, on the issue of SHA. What's your biggest issue with SHA as clinical officers? If you have to explain it to a Kenyan who's watching, what has been the concern that you have had, the grievance that you have raised with the Social Health Authority this far?
Yeah. I think our biggest issue with the Social Health Authority, number one, is going against the law. And by going against the law, that is, they are refusing to empanel clinical officers. But so that Kenyans can understand, empanelment means that for myself as a clinical officer, to see a patient, I need to be recognized by SHA. That recognition and availing yourself so that you can be able to see patients on their behalf, that is what is called empanelment. To empanel Peterson as a clinician, they must first recognize the body that regulates me. That is the Clinical Officers Council. So they refused to recognize any other regulatory body other than KMPDC. And so that is why we cannot be empaneled by then. I know that now there is a resolution, and probably that is something they'll have to do. And that is why we have not been able to even do the minor procedures. You can imagine even the life-saving procedures, some of them like MVA, I know Dr. Dishenga here knows, something that we do at the level 3 and we save lives. Mm-hmm. It has to be pre-authorized. I think even by an obstetrician gynecologist, not even an MO.
For you to do it.
And that is going to deny Kenyans access.
Let's get something clear. Not that you cannot do it, just that the mode of payment has to be different. You can still do the procedure.
We can do it, but not under the Social Health Authority. You have to pay cash.
Yes, that's what I wanted to come out very
Yes, and that is the problem we have with them. But I think the bigger problem is there is something they are not telling us. If you can go against a resolution of the Council of Governors and the PS, what is the interest? And also go against the law.
All right.
And I think we need to talk about the administration of the Social Health Authority, because we have a problem. We have a problem because these people are acting. I know that the ministry had undertaken, and I wish Mheshimiwa Pukose was here because he chairs the health committee. The ministry appeared. They said they were going to recruit, I think that was last week. The people who were there, they are seconded. They were taken from NHIF to Public Service Commission. They were seconded to the Social Health Authority. They are acting, this is the 4th month. They were given 6 months. They have not started the recruitment process. The directors who are there, some of them are seconded from the ministry. There is nobody who is responsible under the Social Health Authority, and that is why everything is failing. It is a system failure.
All right. Lishenga, if you just weigh in on this particular subject matter, the elephant in the room seems to be the issue of empanelment. If you were to go back to what the initial plan was in terms of which regulatory bodies were supposed to be, the facilities were supposed to be empaneled, I don't know what your understanding of the initial agreement was and what is happening right now, even the concerns that the clinical officers are raising. Do they hold any water for you from where you sit?
Thank you. I find it absurd that a clinical officer is not, allowed to do procedures for which they are competent to do, and that has been created by a technicality, I will tell you this, 71% of facilities in Kenya are level 2 facilities. If you combine level 2 and level 3 facilities, it is 91% of facilities in Kenya. So anytime you talk about healthcare facilities, just remember 91% of them are level 2 and level 3. If you ask me who is manning level 2 and level 3 facilities, it is clinical officers and nurses and midwives. So it is totally ridiculous, because this is where the vast majority of Kenyans seek care. It's totally ridiculous for 91% of the facilities where Kenyans seek care that the staff there are not, recognized. That for us has been a very sad situation. I mean, if it's going to be resolved very quickly, we want to see that. If you go to the Kenya Master Health Facility Registry, you will find that even for private sector, the vast majority of facilities are owned by clinical officers and nurses. General practitioners, specialists own a very few proportion of facilities. As a matter of fact, only 9% of facilities in Kenya are level 4, 5, and 6, where you will find, your medical officers, your specialists, etc. So you are denying the vast majority of Kenyans healthcare if you take a policy position that those facilities cannot be empaneled. This
policy position, was it the original policy position? Was it supposed to be a KMPDC affair only, or?
No,
what was the initial agreement?
I mean, it's over ambitious, and also some of the things that we have observed with the movers of this transition is, I would say they became too clever. They just wanted to appear superior in thought. I give you a case in point. Everything we know about the SHA transition now began by selling us the idea that NHIF was bad. Everything at NHIF, nothing worked. It was cartels, thieves, and corruption, and pilferage, and the systems were not working. Certainly we can say that about SHA now. So the idea here, to answer your question about the policy position, the idea here was that people wanted to show that they have brilliant ideas and that we can reinvent the wheel. And yet we have a system that has functioned relatively well for over 60 years. We have been proposing for tweaks in the system, incremental changes, things that have been postponed for many years to be done. So we did not need necessarily to do a lot of the things that we have done. I'll give you an example. I always like to say this. Every time somebody says SHA is working, I remind them that it is not the case. It is NHIF that is working. If you ask yourself, what was the fundamental change that this transition has brought? This transition brought only two things fundamentally. It brought a primary healthcare fund, and it brought an emergency chronic and critical illnesses fund. SHIF is NHIF. By all definitions, SHIF is NHIF. The only thing that SHIF is different from NHIF is two things. 2.75% on payslip and proxy means testing for the informal sector. Otherwise, the fund that we call SHIF is literally NHIF. If you ask yourself today, why is there so much outcry around this transition? Why is it that, because we represent facilities in rural Kenya, we listen to the people talking in the rural communities. They are finding it harder today. So why is there the outcry? I'll tell you why the outcry is. The primary healthcare fund is not working. The emergency chronic and critical illnesses fund, which was supposed to protect Kenyans from harambes, because that is where you're getting people in accidents, that's where you're getting people in ICU, that's where you're getting people on dialysis. That fund is also not working. So,
so to be more direct, what would you give us justification for the transition from NHIF to SHA from where you sit? Is there any reasonable justification you can give?
The only justification I could find is that we needed more money in healthcare. That is the only justification I could find, is that healthcare was underfunded. And on that one, all of us agree. I think Peterson agrees that we were not putting enough money in healthcare. Now, if you listen to our colleagues in government, what they will tell you is that the primary healthcare fund, which is, by the way, state funded, it is a parliamentary appropriation, and the emergency chronic and critical illness fund, those were the increases in funding that were supposed to solve our funding shortage problem. Now, if we are consistently underfunding them, if we are consistently not supporting them, then what was the purpose of the reform?
It beats logic.
It beats the logic.
Yeah. Wachira, coming back to you, if you're to explain to a patient who's watching you right now the lack of empanelment of clinical officers in this old SHA agreement, how does that impact them when they next come to, a health facility near them to look for services? What crisis, awaits them?
Yeah, let me first answer the question that you asked Daktari here, that it is not a problem of policy. The policy is very clear. If you go to the Social Health Insurance Act, it mandates the Social Health Authority, once they receive a list of facilities or a list of practitioners from the regulatory body, they have no option other than to empanel them. The regulations even go deeper and indicate the relevant regulatory bodies. And so it is not one regulatory body. It was not envisioned that that would be KMPDC, because laws must be realistic, and the people who are making the laws knew that the regulatory bodies are many, not only KMPDC, not only Clinical Officers Council. There are many regulatory bodies with practitioners who will need to be empaneled so that they can be able to pre-authorize. But to the patient, and I know it resonates with many of them, when they come to the facility, and as Daktari has said here, about 91%, but remember, we are not only in the 91%, the level 2, level 3. The reason as to why now they'll say clinic officer is because mostly you don't find medical officers there. So we are the clinicians you find there. But even if you go to level 4 to level 6,
there.
In the outpatient, most of them are purely clinic officers. So it's still ourselves. And if you cannot be able to use the Social Health Authority, so the patients are coming to the facility, they have already registered with SHA, but when they come to us, we tell them, we are sorry, we cannot be able to pre-authorize. So this procedure, it's either you pay cash, or maybe you can go to another facility where you can be able to find that. So they have two options. Either, if they have the money, they'll pay out of pocket. If they don't have, they'll have to ask around, do we have probably a facility registered by KMPDC? Where we can be able to use SHA, then they'll be able to go there. Or they can go back home if it's far, like where I come from. And you'll have to sell a goat or something else so that you can be seen. But maybe to put it in better context.
So that means currently the facilities registered under KMPDC are the ones...
Yeah, they're the ones. They are the ones that have the rights to use the SHA. I know from yesterday I've seen now they have opened up for the facilities for clinical officers just when we got into the strike.
Okay.
We are yet to see whether it is foolproof, because now we cannot trust them. But that is what has been prevailing. But maybe to just put it in context, I come from Nakuru County. I come from Mount Narok, a village called Gatimo. From my village...
Let me take you back. They have opened it to mean the facilities registered by...
That now they're empaneling the facilities by clinical officers.
Okay, from yesterday.
They're implementing the directive of the PS and the Council of Governors after 4 weeks after we go on strike.
So it is being implemented, you can confirm.
For the facilities. But for the practitioners, still not yet. So even if they empanel my facility, I cannot be able to do that procedures in my facility. Because you have to empanel both the facility and then the practitioner so that they can be able to pre-authorize. So I'm trying to give a very live example. There is a life-saving procedure called manual vacuum aspiration, MVA, usually done to ladies sometimes due to child loss and things, and they're bleeding a lot. And it's a matter of time. It can actually lead to death, and to shock and death. I'm imagining from my village to the nearest level 4 facility is about 56 kilometers. There is a health center that is less than 10 kilometers. So it's only clinical officers you find there. And by the way, they are competent. They have been doing this. So what if this patient cannot pay cash? They'll have to bypass that and travel 56 kilometers, probably get into shock and die, or probably get organ damage. Even if they are going to live, they might probably end up somewhere in ICU and even use more resources. That is what the patients are going through. That is just a case to show in context what that means when then the people who are nearer to the patient are not given that access. And we must always remember the primary function of the Social Health Authority was to implement UHC. To implement UHC is to give a Kenyan very close to them access to the healthcare services that are of good quality and that do not predispose them to financial harm. And that is what now they are actually going against. And that is why we are saying that they are self-sabotaging the system. That is why I'm questioning about the people who are running Social Health Authority and the fact that there is nobody who is substantively employed there, including the CEO. And most of them are seconded. All right. And saying that there are administrative issues. But we must go beyond the issues that we are seeing and audit and look at what is really happening under Social Health Authority, because it looks like a clear case of self-sabotage.
Self-sabotage. I'll pick it from where you have left it, and even you have reminded us why the transition in the first place. It was supposed to bolster the universal realization of the universal health coverage.
Yes.
3 key issues: access, quality, and affordability. That was what the government hoped that this was going to help us achieve. And Brian, you released the latest, survey looking at the status of SHA. This is is it the seventh? The seventh.
Yes.
Just the key highlights of what you found out in terms of how we are looking like since the implementation of this transition commenced proper. That was in last year, around October. Tell us a bit about what you found out in this 7th cycle of what you gathered.
Okay, so interestingly, the overall score dropped. When we last did the survey in December, around 19th of December, the last survey we released, we had a score, and we look at 11 parameters. So we are tracking 11 parameters for this survey. And we had a score of 46%. The highest score that we have had since October was 47%, which happened in November. Slight decline in December to 46. Now, the latest one in February shows that it's a further decline by 2 percentage points to 44. And I can tell you where.
So we've never hit 50.
No, we've never hit 50. I can tell you where the rain is beating us. So there are a couple of things. One, the SHA portal. This portal, which we use for facilities used for, seeing patients, consistently dropping. OTP delays. Patients waiting for PINs to come through the phone. You can imagine a mother with a child has a fever, OTP is taking 2 hours, 3 hours to come to the phone. They will end up paying out of pocket. They will just say, okay, fine, I cannot keep waiting. How much is that consultation? And that is what is, part of the things that are fueling. So on the SHA portal itself, it raises a lot of questions because we were told that quite a bit of resources will be deployed on making sure that the digital infrastructure is in place. So, if you look at it, have we gotten value? Are we getting value for money on that digitization, the SHA portal? I doubt it. And it's obviously no. And for me, I'll be very interested, and I think providers are saying this, we'll be very interested if somebody will give a bill at the end of this process for the SHA portal. We would probably oppose that because that is not value for money for Kenyans. Kenyans are really struggling because of that portal. Had a score of 22% in December, has 18% now. In December, we had about 80% of providers telling us they keep having problems with the portal. In the latest poll, 90%. Now, if you go granular into that survey, which facilities are struggling the most? Remote facilities, level 2s, level 3s. You are talking about public facilities, because our survey it was cross-cutting. It's not private sector only. It was public, faith-based, and public, faith-based, and private. So if you look at it, we have not sorted out the technology challenges, and in any case, they are getting more difficult. And it looks to us that the early adopters were larger facilities which had more technical support. So for example, our referral hospitals, larger level 5s, they had more support. But as time has gone by, the smaller facilities have been getting in and they are not getting sufficient technical support. The second issue that is dragging down this score is the issue of payments to providers. And it's very interesting. You know, the government has been involved, and it's unfortunate, been involved in a lot of public relations. So let me explain what I mean. It's good to tout payments, you know, saying that, and for this we would agree. Our contract with SHA says payments for clean claims within 90 days. Are they paying before 90 days? 100%. The question is, who are they paying and what are they paying? So when you go into that data, 86% of level 2 facilities have gotten no money. No money whatsoever. And if these are 90%, 70% of our providers, that tells you that 70% of our providers are underfunded. They are not getting money. So if you're paying 11 billion, 7 billion, whatever amount of money you're paying, we need to ask, where is that money going to? And it's not only that. If you consistently ask providers, they will tell you, I am being paid less than half of my claims. When we ask SHA, SHA says we are paying 100%. This is what we think. We think that the CEO at SHA doesn't have visibility of claims, doesn't have visibility of what is actually happening. So it is very likely that a third party is the one that is actually processing these claims, and the work of the SHA officers, who my colleague has put they are all acting, is basically to click a button and pay this. Do they know the total claim value? I have serious doubts that they actually know the total claim value. The third thing... Do
we have a figure we are working with from your...
I think by January, the total, by end of December, the total claims that had been submitted were about 18 billion.
18 billion.
Yes, and you know, so there are a lot of questions around that. How much have they paid? It looks to us that they still owe providers quite a significant, because simple math, if they have paid 11 billion, there's probably 7 billion out there that is not being attended to. And the back and forth between them and providers is, they say we have paid everything. Providers are saying we have not paid everything. So we think that the ERP system that is running claims is not in the control of SHA. Somebody else has control of that and they have no visibility. The third and most pressing thing that we found out in our survey is the issue of NHIF arrears. Now, let me just paint a picture for this. The first schedule of the SHA Act indicates that SHA will inherit the assets and the liabilities of NHIF. Now, simple understanding of that is that the buildings, the NHIF headquarters, the vehicles, the cups, the spoons, all those things were inherited by SHA, okay? At the same time, they also inherited liabilities, which includes monies they owed providers. One of the things that has been very interesting for us to observe is that SHA has been very quick to use the assets of NHIF. You know, very happy to use the buildings, very happy to use the vehicles, very happy to use the cups to serve as tea when we go there. But anytime you talk, okay, fine, you're using the assets. Anytime you talk about liabilities, now they say, no, we don't want liabilities. They have to take the good and the bad. So I'll give you a very good example why NHIF debt is a bad issue. You have facilities today, which, especially level 4, level 5 facilities, which owe specialists money since 2017. These are doctors who performed procedures 7 years ago, 6 years ago. That doctor, that specialist, if you call them today and say, hey, Daktari, Lishenga is here, he needs an appendectomy. That doctor tells the hospital, please, you still owe me money from 2017. So unless it is a cash client, I am not going to come and do the procedure. This is driving out-of-pocket expenditure. The idea that the Social Health Authority is now using, they are paying what we call LIFO, last in, first out. So you're paying current bills. What we are saying is that they must do FIFO, first in, first out. They need to pay historical debt. And it doesn't matter whether you ask public facilities. In our survey, 49% of public facilities said pay NHIF debts first. Before we go to SHA. Only 25% of them said pay SHA. Private hospitals, 61% of them said pay NHIF arrears first. Faith-based hospitals, 51% pay NHIF arrears first. So what we are telling the ministry and the Social Health Authority, it doesn't matter how well you pay SHA arrears, SHA debts, until you handle the issue of NHIF arrears. And it's unfortunate. Civil servants were deducted this money. Do you know the money that we are talking about? It's not money from Kenyans. Kenyans who are contributors, they pay their money consistently. It was government departments, ministries, who deducted their employees' money from payroll and never remitted the money to NHIF.
I was about to ask that question, and I'll come to you, Peterson. How does this fall on the ears of a Kenyan who has been paying NHIF faithfully? It was deducted, this money.
Yes.
Now we are under SHA. It has even increased. It's 2.75% of the monthly income of a household.
Yes.
And actually they say that the working class are bearing sort of like the burden. Some are paying as high as 27,000 annually. How does this fall on their ears when you hear that you are deducted 2.75 at the end of the month, but then again, SHA owes the facilities, not just monies that were accrued under SHA, monies that are date back to when we were still under the NHIF arrangement. Help us understand, the logic behind what's happening and where is this money? All we know is that 2.75% is not part of my payslip anymore, but then we don't know where this money is going.
I think Kenyans are as disappointed and dismayed as I am, because the Daktari, I remember we paid 104 billion for the system. Now you are telling us the system does not work.
The technology.
It's almost a 1-year collection for the chief. The chief collects 133 billion per year. If we paid 104 billion, we paid a yearly correction for a system that simply does not work. How do you reconcile? How do you reconcile that yet we had a system under NHIF that was working, that they could probably have improved? Probably wouldn't even have taken a billion. But then, when we talk about the financing, and especially that is coming in through SHIF, we must agree. We are getting more money than we used to get under NHIF. NHIF used to work to some extent. It may not have been 100%, but all of us have benefited from NHIF. How comes when we add more money, then we are told that it is untenable? Those are the questions that Kenyans are asking themselves. Then the other thing is that, our financial, our model of funding of the SHA, I think it's lopsided. I remember the president saying that I want to change how we operationalize UHC so that we can make it cheaper and easier to attain. And he said that we want to focus on primary health care so that we can reduce the disease burden and reduce the cost, so that then the limited resources we have can cater for health care. And in this, that is why now we have Primary Health Care Fund and the Primary Health Care Act. But when you go down and look at, are we really implementing the PHC strategies? Are we preventing the disease? Because it all contributes to this financing. We are not preventing disease. And I think I can affirmatively inform Kenyans that we are not preventing disease. The CHPs that we put down there, they are very important, by the way. We have no problem with CHPs. But their work is promotion, to give that information. But now they have become scouts for those who are sick. And they're doing a good job that we are getting early detection because they are giving information and helping us get those who are sick. But we are not preventing, we are just getting people early. So the prevention that we are doing is what we call secondary prevention, preventing the progression of a disease now to complications. But we are not preventing the diseases in the first instance. Look at the disease burden in this country. Which are the diseases that are bringing Kenyans to hospitals? I think a majority of them, they are communicable. Diarrhea and vomiting. We have sanitation, what we call WASH, water and sanitation related diseases. And then we have now NCDs, the communicable, the non-communicable, cropping up. Some of them like hypertension, like diabetes. If you would have the real interventions in terms of family health interventions, community health interventions, school health interventions, so that you have a public health officer working with a nutritionist, working with a nurse or a clinician, going to families and profiling their risk status and telling them that from the diet you are eating, from your lifestyle, we can see that probably the man in the family, after these years, you might get this non-communicable disease. We can go to the daycare facilities. Look at those kids. Look at how they are fed, and even from their home setting. And the nutritionist can be able to say, this is predisposing them to this. This environment is going to predispose to either macro or micronutrient deficiencies, and that will lead to these communicable diseases because, of course, their immunity is going to go low. And if we can have real interventions by people who are trained, we can actually prevent disease, and in less than 5 years, I believe we can reduce the disease burden in terms of communicable diseases by 70%.
That was the plan. I think that was the script that was.
That was the plan.
And Shah, you then saying that that is not what is happening right now.
Even when
that is what was sold.
When we were piloting, a team was sent to Cuba. If you look at the Cuban model, it is simply what I'm talking about. But then when they came back, and the reason as to why this group we call the Universal Healthcare staff were recruited during Uhuru's time, the 8,500 and I think 71 of them, was exactly to do what I'm saying. But then it was later changed to become about equipments, to become about other things, the tenderpreneuring. And I think that is where we go wrong as a country. So we employed a group that was supposed to go to mashinani and prevent the disease, but then we ended up posting them to the curative side. And I think we must also talk about the same group because from next year, you remember Mheshimiwa Pukose and Mheshimiwa Mandago, the two sittings of the parliaments came together, and after we went on strike, all of us, on the issue of the UHC, and they agreed that they extend their contract by 2 years and then they absorb them. The contracts will start expiring from April of next year. We have no plan in the budget. I've seen the budget policy. There is no money to absorb these guys who have been underpaid actually for the 5 years they have been working.
There's a plan without the funds.
How can you say there is a plan without the funds? The funds must be there to feed the plan. So there is no plan. But then...
Right now, what we have is a plan without funds.
Yes, but then, especially the clinic officers and nurses in this program, they are the ones who are manning our level 2s and level 3s. So if we lose them next year, then we are getting into a deeper problem. And it's fitting to what I'm saying.
All right.
That even the curative side of the early detection and the early treatment under the PHC, we have not been able to prevent. But even the secondary prevention that these UHC staff are now doing at that level will not be done from April next year, if then we don't plan. And that is why we have called on them to also join the strike, and they have, so that then we can push the parliament and the treasury to put this money in the budget, and it's 3.8 billion.
Come to think of it, we saw some very unfortunate pictures at Afya House yesterday.
They actually had a vigil.
Spent the night in the cold just outside Afya House, And this is not the first time this is happening. Really unfortunate pictures we see when it comes to the grievances raised from our health sector. But Brian, just to take you back, if you are to look at the crisis that probably is looming or is already happening, you will guide me on what's happening in the private sector when it comes to the lack of funding, the lack of payment of claims. What is the likely impact of this, and for a viewer who's watching, a patient who's watching, how will this affect them in the coming days if nothing is done to address, for example, the NHIF arrears issues and the issues you have raised from the survey?
So the private sector has been covering the nakedness of the government for too long. We have actually really tried as a sector to make this work. We have covered the nakedness. People have taken bank loans. People have taken overdrafts. I know people have even taken full Lisa just to make sure that there are drugs in the facilities. There are people who survive on monthly overdrafts. The crisis that is coming, Safin, is that we will stop. We as private sector are going to stop, and we are not going to stop next month. We are just stopping very soon. In fact, as soon as the end of this week, we will stop. We cannot continue.
Stop what exactly?
Stop providing care under SHA. We will stop as a sector.
By the end of this week?
By the end of this week, we will stop. We cannot continue to cover the nakedness of the government and pretend that everything is normal and just go on. Look, I just said this is the 7th SHA transitional scorecard. There is nothing very different in this scorecard. I mean, we have been finding out the exact same problems since 6th of October. And every time this report comes out, we share it with the minister, we share it with the SHA authority, we send it to the PS, we send it to everyone, we even send it to the presidential advisors. I am sure these reports go as far as possible. There is really nothing that they don't know. Where we are right now, I'll paint a picture for you, Safin. We literally every single day, I get phone calls from hospital owners around Kenya. These are old people, some of them, who have been invested in this sector for 20 years, 30 years. They have gotten into diabetes. They have gotten into hypertension. Some of them have suffered strokes. Yesterday, I got a call from a university student. I don't know you know how they got my number. He's telling me, my mzee, this is a medical student, by the way. He said, my mzee runs a small facility somewhere in Nyamira. This is how he has taken us to school. This is how he has educated us. The portal for the university was closed yesterday. I have not paid school fees. This issue of payment to facilities is now going beyond patient care. It's now going to cripple families. It is breaking homes. It is getting people to lose their entire life savings, their entire work. And guess what?
And what percentage of health facilities are we talking about?
This is, okay, so I will tell you, I've already told you, 86% of level 2s, no money. But I can tell you that all the facilities in this country, I'll give you a good example. Just go to Nairobi, anywhere around this capital city, to any of the large hospitals and go with your civil servant medical scheme, find out if you will get care. They have already suspended care. The large hospitals in this city are already suspended care. They just don't do press conferences. It is the civil servants who are going to those hospitals and being told, we don't accept civil service cover. Who has been covering that nakedness? It is the smaller level 2s, level 3s, level 4s who have continued to provide care to civil servants despite the fact that our larger brothers have already pulled off. So what we are saying is very simple. Enough of that. We are not going to take any of it. If they do not sort out the issue of NHIF arrears, and by the way, we will not even give notice. We are saying by the end of this week, we as private sector have had it. We are not going to provide. And look, they keep us telling us separate SHA from NHIF. You cannot separate SHA from NHIF. SHA inherited NHIF liabilities. It is their responsibility. Right. Let me just explain something else, Safi. We have a situation in SHA where you have no idea who is being paid what. And the reason why this is happening, I am starting to believe it is intentional. And just to add on what Peterson was saying about the fact that literally everyone at SHA is in acting position. Literally, all the workers at SHA, they cannot even do the right thing because maybe if I stand up for what is right, I might not be considered for employment. Starting all the way from the CEO to the lower staff. When we are talking about these issues about responsiveness of SHA, when providers call in and say, I have a problem, who is it that is responding on the other end? SHA employees who are former NHIF employees had only a 6-month extension of contract, which is now 4 months have already run. It is in the next 2 months their contracts are over. Tell me how those personnel, those providers are going to be able to look through claims and verify. The other fear, just to finish this, the other fear we have as providers, if you are going to lay off NHIF workers, if you're going to lay them off, a lot of our claims were paper claims. Some of them are in branches all over the country. The person who knows the claims for this hospital, they are under her desk. This is the employee that you are now going to sack, and then you expect Facility X to find a historical record of their claims. They are setting us up for failure, and we are saying enough. So we are not going to continue providing services under that current situation.
By the end of the week?
By the end of the week. Okay. Just a final point. On outpatient services, Kenyans are consistently telling us that outpatient services are a pain. everywhere. You go to hospital, there is no single place in this republic where you are getting outpatient services without going back to your pocket. NHIF had a very simple formula. I am registered, I select my hospital, the hospital gets paid an X amount of money for all the people who have selected the hospital. Now, because we must prove that NHIF was bad, we have come up with another formula called global budget and weighted diseases. And nobody has, by the way, there is no single facility in Kenya.
I'm really pressed for time.
I get it. I'm just saying that outpatient services in this country, we have to revert to the old model which was working under NHIF. Let us not try to be too clever. It is a simple mechanism. If you have 19 million Kenyans who are registered, tell them to choose their hospital for outpatient and then pay those hospitals for those 19 million Kenyans. Why does it have to be so difficult?
All right. Big point there. By the end of this week, private hospitals are going to stop offering services under SHA.
By the end of this week. So
by the end of this week. That is why you started by saying it is hot, eh?
It is very hot.
Wachira, what's the way forward now since the strike began? I mean, what has happened in the hours that have preceded that, and what is expected, in the coming days? You also said it's hot.
Today is day 2.
It's still hot?
Yeah, it's very hot.
Yeah.
Today is day 2 of our strike, day 1 of the UHC strike. And I know it's not good for the patient, but I want to assure the patients that what we are doing is for their own good, so that tomorrow they'll be able to access better health, even access it in the first place, because sometimes we are there, but you cannot be able to access it. And the issues that are keeping us out, other than now the SHA, I have talked about the issue of UHC. UHC must be budgeted for so that we absorb that cohort. It's a cohort we cannot do away with. And I think we all agree to that. It's only that planning is a problem. Number 3, we have in our return to work agreement, we have been able to negotiate the CBS with both the ministry and the county governments. They are telling us they are waiting for Treasury and SRC, and we have told them that we are more than happy to stay outside and wait with them until then they can get that response. But I must say that the problem with SHA is that SHA is being managed at the Ministry of Health because nobody is responsible at SHA right now. And the decisions are being made at the Ministry of Health. Even the issue of delaying our pre-authorization is an issue at the Ministry of Health. And the other thing is cartelism. The cartelism is back, and I'll keep saying this. And the cartelism is by monopolizing healthcare delivery. We know the players, and the players within SHA, within the ministry, and now the KMPDC is being recruited into that. We must call them out. But in conclusion, let me say this, that I want to appeal to the president. I have met the president twice, once in the Catholic University, and I handed him the memorandum on behalf of the health workers. We met when he was signing those laws. I was in State House. And one thing I can tell you, because I've heard what he has said, I think his intention is clear. He wanted health to work. But I want to tell him that the people who he has given the responsibility, and especially under SHA, they are really letting him down. Under SHA, even from the chair of SHA. And we don't want to talk about some things here, but we know the things that are happening within and some of the people who are sabotaging the system there. Right. And that is why we are asking the president, can you please clean up SHA? Can you remove everybody who you can be able to remove and bring in new blood, people who understand? I'm sure if you brought in somebody like Dr. Rijenga here who has been in the system and understand the other side, they'll be able to help us implement the UHC. But now we are bringing people with conflict of interest. These days I'm told that some of them are called emperors within the SHA. You cannot even move a pen without asking them. They are not executive officers.
Well said, Peter.
I don't want to get petty.
All right.
But what I'm trying to say is that there is a failure in the administration of the Social Health Authority. It is coming from the management, and the president should clean it up and have substantive officers so that SHA stops being managed from KMPDC and from the Ministry of Health.
Thank you so much for your time. Unfortunately, we've run out of time, and it's also very unfortunate that several months down the line after the full rollout of the Social Health Authority, we are still talking about the implementation quagmires. We have not even, covered the ground that we ought to have covered after such a time. time in the transition that was meant to ensure access, to ensure quality, to ensure affordability of healthcare for every Kenyan, including that who is in the most remote part of this country. The UHC strike, day one, the strike by the clinical officers is entering its day two. And also we are having this conversation at a time when RUFA has given us a transition report that is painting a very grim picture about the progress we have made as a country when it comes to the transition from NHIF to the Social Health Authority. And that is the status of our healthcare this particular morning. Hoping to pick up this conversation in the near future, hoping also that we will have solved some of the pending issues that we have discussed this morning. Thank you so much for creating time for us. My name is Safin Acheng Ouma.